I'm at the York Management School today. I'm perhaps just something about my journey. So who am I? Now, it's a bit of an existential question. I actually don't know who I am, but I can tell you a little bit about my professional journey in this sense. So indeed, I have a Bachelor and Master of Science in Industrial Engineering, also known as Management Engineering, so Ingegneria Gestionale, or I should say actually Laurea Vecchio Ordinamento, because at that point, you know, it was, I think, the borderline between Vecchio Ordinamento and Nuovo Ordinamento. I graduated in 2004, and for the whole duration of my degree, I was a student at the Collegio Superiore, just like many of you. So between 1999 and 2004. I then got my PhD in business administration in 2009. And meanwhile, I was a visiting scholar at the Indian Institute of Management in Bangalore between 2007 and 2008. And I think I remember quite clearly when I went to Rosa and I said, Rosa, you know what? I would like to go to India to do my PhD fieldwork. And I think she shook a bit on her chair. But then she was always, you know, as usual, very supportive. And she said, okay, you know what, go and do your experience. We were, of course, in touch all along. It was quite an experience for me. It was something, well, different than what my classmates at that point were doing. So my PhD classmates, but I really wanted to do that. Because, well, I was studying knowledge flows within industrial clusters, and the cluster of Bangalore was particularly well known at that point, the IT cluster. And I really had a sort of a pull towards India, towards such a different culture, and for me to understand something more, so to make it sort of a personal experience in that. And I think my experience in India sort of turned a switch with respect to what is the rest, let's say, of my professional career. I was then a postdoc at the Maastricht University India Institute, which was an interdisciplinary center connecting researchers with a focus on India at Maastricht. Then somehow, and we can talk about this later if you're interested a little bit how careers develop. I started collaborating with the medical faculty at Maastricht University, and I took on a position as assistant professor at the Care and Public Health Research Institute at the Department of Health Services Research. So as a matter of fact, I brought my management theory, management background, even business administration background in the healthcare domain. So I was actually teaching doctors or hospital administrators with the management theories behind in the background. And that was also one situation in which I had to push myself out of my comfort zone because I didn't know absolutely anything about healthcare organization, healthcare system. So it was really a learning trajectory for me. And I remember very well also then, you know, having this relationship with students in which I would bring my theoretical knowledge and they would bring their practical knowledge in an exchange that was quite fruitful and rich. Then I moved to Tilburg University because studying healthcare was interesting and healthcare organization was interesting, but I needed a broader perspective about, let's say, complex social issues out there. And Tilburg at that point was launching educational program on global management of social issues. There was an interdisciplinary position available, and I thought, okay, let me, you know, go for it. It went well, and I had 2 wonderful years at the Department of Organization Studies. Meanwhile, I launched a new master program in global management of social issues, which was also combining human resource studies, organization studies, and sociology in an interdisciplinary program. And I was also program leader of school level theme, adaptive societies, organization, and workers. Then somehow, mostly for personal reasons, I moved to the UK just last year. And since then, I'm a chair in management, so a professor in management at the University of York, at the York Management School. Not sure it was a good move between, Brexit and COVID-19 crushing British universities, but yeah, here I am. So what are we considering today? I would like, first of all, so this lecture is about management, organizational learning and adaptation to understand or to address complex social issues. So let me start by the Sustainable Development Goals. We know that modern societies...
cercare una dimensione...
Oh, sorry, I hear somebody talking. Okay. Modern society face compelling social issues, complex global challenges, which can be social and environmental challenges. They're complex. So think about poverty, think about climate change, think about healthcare inequalities, think about glass ceiling for women in organizations. I was telling just before to Dario and Rosa that we are studying the processes and decision processes of the Comitato Tecnico Scientifico in Italy. That is the main, scientific, let's say, body that advises the Italian government around the COVID-19 containment policies. Interestingly, I mean, we are looking at specifically how the expert advice is embedded into the policies, but, talking to the members who have been very, very available to us and very kind in that, there was a point where they realized, looking around the Comitato, that there were no women whatsoever out of 20 members of the Comitato. Now, why was that, and were they responsible for that? Well, talking to them, we realized that the problem is a problem that is, that has to be traced early on, because the Comitato was sort of composed with rationale of institutional representation. So all the people who were heading the main institutions, Istituto Superiore della Sanità or Consiglio Superiore della Sanità, Protezione Civile, and so on, were headed by men. And hence, naturally, those men converged into the Comitato Tecnico Scientifico, so into the CTS. So why there is this gender imbalance still today everywhere? Let's think about human rights violations, think about sustainability. So the difficult task to combine economic dimensions, environmental dimension, and social dimension. And think about the pandemics. Currently, we are all experiencing COVID-19 that has, turned our lives upside down. But also others, drug trafficking, rising mental issues, of course, natural disasters. And what all these problems share, they are all wicked problems. So a traditional problem is understandable. We can understand the beginning and the end. We have typically one or two intervening causes. We can clearly pin down what is the cause, and hence what is the solution to the problem. In the case of a wicked problem, it's not possible. So we don't really understand where it starts. We don't really understand where it ends. There are many different intervening causes to the problem. Think about the pandemic. It started off as a public health emergency, but then, now it is becoming a problem of economic recession, a problem of mental health issues, of people isolating, of teenagers being, stuck at home without proper social interactions. So what is the solution? Now you see many different voices and a polarization of views around what the problem is and also what the solution is. And this polarization of views, this clash of values, is quite typical of wicked problems. Now, early on, let's say we had the Millennium Development Goals, which were guiding government in their investments towards main challenges, societal challenges. You know, these Millennium Development Goals were 8. They were very clear, very focused. So eradicate poverty, achieve universal education, reduce child mortality. However, and they did an amazing job in sensitizing governments and sensitizing and directing investments towards these issues. At the same time, they were typically problems that were associated to low middle income countries, problems that were quite fragmented, and problems that were tended to look at the average. So we have to eradicate poverty. We need to hence increase the average income of people. So they were not that much looking at inequalities within societies. Now, these were now replaced in 2015 by the United Nations Development Framework. 17 Sustainable Development Goals. Well, beyond the graphic improvement that we can see, these 17 Sustainable Development Goals can be considered as an evolution from the Millennium Development Goals, especially because, first of all, they are global. So they do not only affect low middle income countries, but can be considered as important and relevant and compelling also for Western economies, industrialized economies. They are interconnected, and this is a very important point, and they are focused on inequalities. So think about inequalities in the UK, where I live. If you take the tube and you go from Westminster East, I guess, every tube stop is equivalent to 1 year drop into the life expectancy of people. In the wealthiest neighborhood, you have a life expectancy of 80 plus, 85. In the poorest neighborhoods, you have a life expectancy of 65, something like that. Imagine that kind of inequality. So that's why these Sustainable Development Goals are very much relevant also for the current and our societies and our industrialized society, in addition to, of course, the low middle income countries. Importantly, all these goals are interconnected. So you cannot think of, improving maternal and child health, which is a big issue still in sub-Saharan Africa and in low middle income countries. And that very much reflects the divide between poor and rich in the world. 99% of maternal deaths still happen in sub-Saharan Africa or in low middle income countries. So you can't act on that without considering gender inequalities, so the power dynamics within the household. You can't tackle that without considering, addressing poverty, without addressing low education, without giving women the opportunity to perhaps start their own enterprise, and so on and so forth. So how can business and new organizational forms address these problems? So today I will get you a little bit through my studies on poverty, on health, and ultimately on reducing inequalities. Poverty alleviation. Now, the first attempt of business theories to alleviate poverty was the so-called base of the pyramid theory or approach. That was, let's say, conceived by Prahlad and Hart in 2002. Now, what they thought is, well, there might be a fortune at the base or at the bottom of the income pyramid. Now, this is the income pyramid, and you can see there are 4 billion people living with less than $10 a day in a situation in markets that are fairly rural, underserved. There is an informal economy, so it's not that these people don't work or do not have any income or do not have any money to spend. However, and it is also a market that is inefficient and where you find little competition. So as a matter of fact, there is an opportunity for business to thrive. So what they decided to do is to address this base of the pyramid as an important financial and strategic opportunity, because if you're able to sell a product or a service to 4 billion people, even if you make a very small margin, then it becomes really a fortune. And it is also, of course, a social and humanitarian opportunity, because by selling them or by addressing a market, tapping into a market that wasn't explored before, you might be able to lift them out of a situation of disadvantage and poverty. Now, if you were here with me, I would ask you, is this a win-win solution? Is this a new era of sustainable inclusive capitalism? Well, the hype was big, and there were many people believing that it could indeed be. We studied this topic together with specifically one of my co-authors in India. Now, the first point to understand is, how do disadvantaged communities differ in their purchasing behavior? Is it only about income, and how does income affect other aspects of life? It was quite naive, turns out, to think that you can just, take a shoe that wealthy people use, you make, you take out some functionality, you develop a product that costs less, and then they'll buy it. This was the biggest naivety of, let's say, the base of the pyramid signatories or ideators. That's because they didn't really take into account that these people live in very different places. So they live in rural areas, urban slums, shanty towns that are difficult to reach, and where the kind of lifestyle that you lead, the kind of values that you have, the kind of social interactions that you have, the importance of beliefs and religion is enormous. And cannot be compared with what usual traditional wealthy consumers experience. These people, disadvantaged people, are poorly exposed to traditional marketing channels. There is a huge heterogeneity of BOP communities because of their very peculiar makeup. You could say the traditional market are sort of forged to be towards being isomorphic. So what I like is what my neighbor might like, or it's what somebody in the United States might like. We might differ slightly, but we are exposed to the same marketing channels. We watch televisions, we watch Netflix, we read books, we are fairly educated, and so on and so forth. But when it comes to disadvantaged communities with poor level of education, living in difficult circumstances, perhaps only listening to radios, perhaps they don't have a mobile phone, perhaps they don't have a television, then the heterogeneity in their aspirations, in their wishes is huge. So what could work in one village might definitely not work in another village at the BOP, as we say. So in this disadvantaged and difficult markets. And in fact, the initial attempts to tackle these markets failed. For example, the Nike's World Shoe, Simputer, which is actually a local company that I interviewed, and also the Philips Chula, so the improved cook stove that Philips was trying to sell to disadvantaged communities. They thought, okay, these people, they have a problem with indoor pollution because women are cooking on these stoves that use highly polluting fuel, and that of course are not technologically cutting edge at all. And they thought, so these stoves produce a lot of smoke and these women cough all the time. And they thought, they will buy it in no time. But of course, that was not the case, because the women were not that much concerned about their cough, which they actually thought it was a way of life. Actually, we did some interviews in the slums, and in order to understand what could be a solution to indoor pollution. And we said, you know, why do you think you're coughing? And one woman responded, I cough because I'm a woman. Because all other women were coughing, and she just didn't make the connection between the indoor smoke and the fact that she was coughing. Hence, what they will be most concerned about is the taste of their food, whether their chapatis would taste the same with this new strange technology that some people is bringing to them. So there's a lot of reluctance. And hence, all these products that these multinational corporations were trying to, you know, push on the people miserably failed. So my co-author and I studied why multinational corporations were lagging behind local companies in serving the BOP. And we discovered that more than affordability, there was really a problem of acceptability, awareness, and availability. So multinational corporations needed to come up with an entirely new business model to serve these communities. Affordability is not the main issue. So the price of this product is not the main issue. One main issue is the socio-cultural acceptability of this product. In this case, we studied Hindustan Unilever, so big multinational corporation, Anglo-Dutch, versus Nirma and Care, which were two local companies operating in the detergent and shampoo markets. Now, interestingly, Nirma, which was, I think, the soap, detergent, the detergent, Nirma product was harsh, which to wealthy consumers, to traditional consumers, this would have been a negative point. Instead, for BOP disadvantaged communities, this was considered as a positive point, because the fact that the product was harsh, it meant that it was effective for them. That was perceived as positive by BOP consumers. And this understanding of, and this sort of grasp of the perceptions and of the needs of the people that were served was crucial in understanding the success of Nirma and Care product and offer with respect to the Hindustan Unilever. Another point, yes, when you look at the shampoo category, and these are quotes from our study, a rural consumer working in fields will require a higher level of cleansing compared to the urban counterpart, because they work in fields, so the hair gets dirty, who seeks more conditioning for making his hair look more shiny, soft, and bouncy. So completely different needs, and hence completely different acceptability level of the product. Now, awareness. So Hindustan Unilever hired models, superstars, people difficult to relate to. Instead, Nirma and Care used day-to-day characters. They used transportation vehicle and jingles. So they adapted their marketing channels to the needs and to the perception of the BOP consumers. Availability. Hindustan Unilever distribution model was very pervasive, but very expensive. Instead, Care used the typical huts and mailers, so the typical markets, fairs, local fairs to reach rural communities. And affordability. So Nirma and Care had a strategy of low cost and differentiation at the same time. So they managed to really push down their price point by, for example, selling shampoos in sachet, so in small quantity that were easily affordable. A strategy that was then copied by Hindustan Unilever. So the conclusion of our article was that multinational corporations' problem in combining BOP and TOP, so base of the pyramid and top of the pyramid markets, and the local needs with the global needs of a multinational corporation was the main determinant of their failure. And here we coined the term institutional dualism. So they were pulled and pushed by different demands and claims. Another point, so you might have thought about I don't know if this is something you're thinking right now, but you know, we talked about shampoo and we talked about the detergent. There is an important question here to be asked. To what extent providing products and services to the poorest individuals lift them from extreme poverty? So doesn't that sound a little bit like a paradox? Because you use some, or you claim some of their disposable income for products that might not necessarily be important for them or beneficial for them in terms of improvement in their way of life or in their health outcomes. Now, it depends really. It depends on what you provide. Is this the kind of product and service really necessary to improve their living conditions? Or are we creating unnecessary aspirational demand? So are we creating cognitive dissonance here because we are exposing these people to products and way of lives that are westernized and something that they do not necessarily need? And it depends also how you provide it. BOP communities in the first, let's say, conceptualization of the BOP approach were viewed only as consumers. So it was essentially a little bit of an imperialistic and exploitative approach, really. Instead, it would be much more beneficial if these people could be involved as producers, as sellers, as suppliers, maybe as think about farmers, poor farmers, and as entrepreneurs. So if they could be embedded in the business model in order to spur local economic development rather than just see them as potential markets. So this was really the idea of the BOP Business 2.0, which is very much about promoting a participatory, empowering approach. So it tries to gain communities' trust, tries to reshape their identities and foster a sense of belonging through co-creation approaches. So what we, me, my co-author, but also, my PhD students over the years have really understood that it is of utmost importance when serving these communities because of the enormous institutional divide and the enormous difference and distance between the innovators and the recipients of the innovation is to understand their perceptions, understand their point of view, their needs, and how they conceptualize those. And there's also the importance of local partnerships and ecosystems with non-governmental organizations. And that's where the 17th development goal, sustainable development goal, comes in. It is important to foster local partnerships to be able to really understand and serve these communities. And in this sense, we have some current projects on cross-sector partnership, really for sustainable farming and inclusive maternal healthcare delivery in Sub-Saharan Africa, South America, and Bangladesh, especially in the Rohingya refugee camps. Well, this is a hoping to be project because we just put in a research bid. So we hope that will be funded. Now, good news about poverty. Poverty has decreased enormously over time. However, there has been an enormous rise of inequalities. Remember before we were considering the average levels as opposed to, variance as opposed to the difference, the standard deviation. So currently we are in a situation in which 1% of the population owns as much as 99%. And also there is a point of what is poverty? So far we have used somehow income level to define poverty. Less than $10, then you're poor. Less than $2, then a day, then you are in a sort of humanitarian situation. However, poverty is a much deeper status than that. And in this sense, it is important to also keep in mind that the very definition of poverty and the very definition of development has evolved over time. Particularly Amartya Sen, a Nobel Prize winner, expressed a concept of powerlessness as attached to poverty. Poverty was defined as powerlessness vis-a-vis the local social system, patriarchy, religious fundamentalism, racism, culture, illiteracy, and income and educational disparities as key variables. So it's not that much that you have a specific income, but it's mostly that situation of disadvantage leads you also to less education and fewer opportunities to express your voice and to participate to the democratic process and to have the power also to make your own decision and to shape your own life and to take your own opportunities. Now, having considered, let's say, studies about poverty alleviation, I would like now to bring towards the connection between poverty and health. A lot of my studies have been about healthcare and about healthcare organizations, healthcare delivery, healthcare models, healthcare systems. Now, somebody say there is a poverty trap. So low income leads to low level of education and healthcare, which leads to low levels of human capital, which leads to low productivity at a micro level. Then at a macro level, low income leads to low saving, low investment, low economic growth, and again, low income. Now, this could also be, and this is in a from an intragenerational perspective. So within our current generation, within our current society, this, of course, trickles down in the next generation because, poverty means for small children a lack of proper cognitive stimuli, a lack of proper care, which goes into childhood, disadvantage of childhood in terms of poor education, poor parent support, poor socialization opportunities, which leads to disadvantage in adolescence, lower outcomes for adulthood, and then lower outcomes in the old age, or lower quality of life in the old age. Now, we could also talk about health-related poverty trap. So poverty leads to poor health, which lead to lower capability to work and study, which again fits into poverty. Poverty also leads to a delayed healthcare treatment oftentimes. So people tend to ignore ailments or early signs of poor physical or mental health, which leads to delayed treatment. The situation becomes very serious, and that leads to catastrophic expenditures for health, and especially in countries like India, where about 80% of healthcare costs are out of pocket because there is very low governmental expenditure in public health. So not only poverty leads to poor health, but there's really a coevolution between the two. How to improve healthcare at the base of the pyramid? So for disadvantaged communities, for poor people. Now, delivery of healthcare adds one layer of complexity with respect to other services, because healthcare, think about it, there is an enormous asymmetry between patients and doctors. Even for patients like us who are, fairly educated. And healthcare is enormous. Healthcare, so the meanings of health, what we understand by being ill or being healthy, what we expect in terms of treatment, what we feel comfortable with in terms of patient-physician interaction is enormously shaped by cultural and sociocultural and socioeconomic aspects. So sociocultural aspects do shape patient expectation and hence also the nature of the product and system characteristics. Now you see a strange word here, that's a kraamzorg. I lived for 10 years in the Netherlands and I delivered 2 children there. And I can tell you, and that's my favorite example of to illustrate how different are healthcare systems and how sociocultural expectations shape the way healthcare is delivered. In the Netherlands, women still take pride in delivering at home. You are being given stuff to prepare your bed at home for delivery. So you have to lift your bed substantially so that, midwives do not have to bend that much. So everything, the whole system is conceived so that women can deliver at home, because that's considered nice, that's considered cozy. They even have a word which is typically Dutch, that is gezellig, which means so much fun altogether. And in fact, they consider going to the hospital as something particularly annoying, and they do that only when complications arise. Although the system is trying to change, because of course that this led to levels of infant mortality and maternal mortality that were quite higher than the European average. And you also see the differences in public expenditures on health across countries. You see the United States is by far the highest, and this is not because they are the healthiest. On the contrary, Italian people or Italian system, the Italian healthcare system is quite efficient and with quite good outcomes, but we don't spend as much. That's how the system is shaped. For example, again, in the Netherlands, you cannot go to the specialist if you're not referred by general practitioner, which is something unheard of in Italy, where if you decide to pay out of pocket, you can of course consult a specialist, and so on and so forth. Well, another very famous trait of Dutch doctors, and then I stop with the Dutch part. They are very well known for telling you, whatever you have, go home, sleep, and take some paracetamol, which again, it's very much annoying for a Southern European who is instead used to, being advised and being recommended all kinds of, antibiotics or treatment or medicines. Now, these sociocultural traits determine, coming back to the base of the pyramid, they determine that so many low-hanging fruits that could be plucked and that would dramatically improve global health, they are not being used, such as malaria bed nets in sub-Saharan Africa, toilets. There is a major problem still of open defecation in countries such as India, where it's just a cultural and social practice to do, which of course leads to all kinds of diseases, poor sanitation, and poor practices and poor hygiene. However, it is very difficult to eradicate. Malaria bed nets, just putting the bed nets putting the net on the bed would shield people from malaria mosquitoes. However, people somehow don't do that, even when they are provided these bed nets for free, because they do not necessarily trust the supplier, they do not necessarily understand the benefit of those. So it is actually very well known and well documented, women using these bed nets as veils during weddings. But also chlorine or RS solution and chlorine to reduce diarrhea and disinfect water. Diarrhea is one of the main causes for, actually I think the first one, for infant mortality under 5 in the world. Breastfeeding, it is so simple, it is so healthy, it can prevent diabetes, it can prevent obesity, and still many women decide not to breastfeed. I'm not talking about the women when things go wrong, but I'm talking about women who expressly decide not to breastfeed or reduce the breastfeeding period for whatever reason. For example, in the Netherlands, once again, and then I stop talking about the Netherlands, once again, there are so many women who decide from day one that they will not breastfeed, or improve cooking stove, immunization, family planning. So it is extremely difficult to provide these services or to even introduce health enhancing technologies in these settings. And that's because this is an excerpt from Banerjee and Duflo book that is called Poor Economics. Banerjee and Duflo are the economics Nobel Prize winners from 2019. They studied poverty with experimental approaches. The book is brilliant, so if you want to have a good read, I strongly advise it. So what the lack of demand underscores is perhaps a fundamental difficulty of the problem of health. The ladders to get out of the poverty trap exist, but are not always in the right place, and people do not seem to know how to step onto them or even want to do so. So the thing is, there are many determinants, there are many aspects that determine the lack of demand for these services that could be life-saving. Idiosyncratic beliefs, norms, and values, attitude towards labor pain. Women in Uganda do not go to a healthcare provider because they think they should endure labor pain as part of being women, as part of being mother. Gender dynamics, of course, within the household, women are not always able to make decisions. Religious constraints, sometimes because of religious belief, only female nurses and doctors are allowed to treat a woman. And health literacy and difficulties to understand the importance of basic hygiene norms. And again, the health literacy is, of course, an important factor. You remember before I made this example of I cough because I'm a woman, because they just don't see the link between the smoke and the respiratory problems. Now, we went and looked with several PhD students into these issues to really understand how slum dwellers really conceptualize health. And we discovered that it's really important to achieve an understanding of self-construction of health meanings. What we mean by health is shaped in the realm of physical, psychological, spiritual, religious, cultural practices, and geographical location, the slum setting. Of course, in a slum setting, you're exposed to many difficulties. For example, this woman, there is no way in relieving your stress. You have to leave your kids back home with your main door locked and no one to look after. Many women like me goes out, so you cannot say, you cannot have anyone to take care. While we are away, we constantly fear about the safety of our child. This struck me particularly because, my grandmother was living in such a situation, and she did leave her children behind quite frequently. We understand health as happy from inside, but when I see many women here being beaten by their drunk husband, I feel though they show happiness, they are very, even though they show happiness, they are very sad from inside. And when we are distressed from inside, you're not healthy. Now, there's also an element of once you feel unhealthy, where do they go to disclose their illness? Well, this is very much the outcome of a complex nexus of gender, type of illness, marital status for women, type of confidant and type of providers. So here again, one woman mentioned it is very embarrassing and equally unmannered if you talk about female problems, even when your father-in-law is in the other room. So not present, but in another room. And there are all kinds of situations in which people are not supposed to talk about healthcare problems. It's not just women. There is also a quote from a man who says, society has not told us to suppress serious problems, but sometimes we have to do in order to secure our and the family's position in society. So disclosing illness can lead to marginalization and ultimately to really problems from a society in terms of social status within the community. And provider choice. Public healthcare infrastructure, unfortunately, are often of poor quality and they are perceived as not of good quality. So what base of the pyramid patients typically do is to delay treatment and instead gather money to go private, which of course, however, leads to enormous expenses. Especially formal allopathic healthcare services are seen as the last resort, especially for women. They feel that it is very important for them to go to traditional healers, people who are completely unqualified, but this is people they can talk to, people who share the same sociocultural background, people who are willing to listen and to understand, and that would offer traditional remedies. Now, we studied also provider choice, and there's a lot of reluctance to go to English doctor and suspicions towards traditional allopathic medicine. One woman probably said, I feel very annoyed because although the doctor can easily and in a simple way explain things in our language, he unnecessarily uses all those English words and deliberately confuses us to see the fun. Which I don't think he did, but English medicines act well upon us even when illness is in its late stage. So they use English medicine as a last resort. So we studied all these dynamics in a qualitative way, and this is a grounded theory approach. So we go in the field, we listen to the people, and we try to distill the main themes and the connection between these themes. Now, what we discovered is that there is really an aspirational demand for private healthcare because it is considered of better quality, because it is held as legitimate and respected by the community, and hence ultimately that's why people choose for private healthcare provider. So the provider choice comes really across as a sociocultural process. And this is our study on sustainability. Now, how do we reach these communities and devise appropriate business models? Now, a business model is a structural template. We use it quite often in business studies. It is a structural template describing how a focal firm transacts with customers, partners, suppliers. That is how it chooses to connect with the factor and product markets. Typically, there are three elements. There is a value proposition, so the solution offered to a particular problem or customer need. There is a value creation, so internal and external value chain resources that allow you to create value and deliver the value in the form of products and services. And there is a value appropriation, so ways through which part of the value created flows back to the organization in the form of profit. Now, we studied several organizations that are able to deliver healthcare services in India with a commercially sustainable model. And these are the first two ones particularly are really famous. They have been studied by, Harvard Business Review, and they are illuminating. This is Aravind Eye Care, Narayana Rudalayala, and they're both enormous hospitals in, I think Aravind, the first one is an eye hospital, and they do, I think, 1/4 of all the cataract surgeries that the NHS in the UK does for 1,000 of the cost. So they have a model that allows them to really push down the cost. And from a quality point of view, they have fewer complications than what happens in the NHS, in the UK NHS. GE Healthcare, Vatsalia, Sulab International that, installs toilets. Toilets is another problem, because of this open defecation practice, and also because of religious beliefs. Even if you install a toilet in people's home for free, they wouldn't use it necessarily. And that's another example of how you need to devise a model that is socially acceptable for them. So in addition to value proposition, value appropriation, and value creation, we discovered that, sorry for the wordplay, that there is a value discovery phase that needs to precede the value proposition phase, and that encompasses the organizational effort to increase awareness, that needs to act on the patients so that they recognize their health need, they become aware of the solution, and they believe that the solution is good for them. So the only possibility is to get them on board in this situation. So you need these companies, so their competitive edge was in the fact that they managed to co-identify a socially acceptable solution with the communities, with the beneficiaries. Now, so it's a business model, so it's a mechanism, and I'm an engineer, so I like mechanisms. So we go from engaging BOP patients and communities to leveraging local human resources for health and suppliers of innovative medical technologies to pursue then low-cost care through cross-subsidization, for example, and economies of scale. But the point of departure is really engaging BOP patients and community. So conduct a really in-depth need assessment. How do we do that practically? Well, we used a lot of in-depth qualitative research. Another possibility, which is something that we have done more recently, and we published a few pieces on that, is to use discrete choice experiments. So questionnaires in which people have to choose between different profiles of a product and service. And that allows us to understand which attributes are most important in defining preferences, product preferences. We have done this recently in the case when studying menstrual products, which is a big deal actually in BOP communities, because still, because of poor menstrual management, little girls are still missing school days, women are missing work days and even lose their jobs. So it is important to provide a solution that is, however, socially acceptable. And what we discovered most interestingly is that the environmental impact of menstrual product is the one attribute that determines choices, preferences the most. And another method that we're using more and more is qualitative comparative analysis, so somewhere in between quantitative and qualitative methods. We can discuss this a little bit more if somebody's interested in the methodological details. Now, how do we evaluate? So, okay, we talked about the business models, we talked about the Sustainable Development Goals. Once we deliver products and services in these communities, how do we evaluate the social impact? Now, one perspective that I think is very, very important, and this is something that I'm pushing more and more in my research, in my studies, in my education, is the perspective of a complex interventions. So everything that we are doing, delivering a product, creating a new service, creating a new business model should be considered as a complex intervention in a complex system. So we are ultimately perturbing a complex system that has many different interactions in a way that necessarily has unpredictable outcomes. You see here some characteristics of complex interventions in terms of a large variety of outcomes. There is no one-size-fits-all interventions. Local adaptation and flexibilities are most important. We have multiple target groups at different organizational level. We have a large number of interacting components. And the interventions need to change multiple interacting behavior. So really complex interventions are changes in complex interrelated system and human behaviors, where it is important to understand how parts of the system interact to produce individual or higher level outcomes. Now, we recently used also this lens of complex interventions and complex systems to analyze the COVID-19 pandemic. And there's a recent opinion article just this summer on world development. And importantly, there is a high risk of unintended, unpredicted, and unpredictable adverse consequences. Think about the COVID-19 policies. You know, there has been the curfew measures, so the curfew intervention. So they said, okay, we close all the bars, sorry, and restaurants at 10 o'clock in the evening. It's gonna be good because we prevent people from having their alcoholic interactions in which they are less careful, and so on and so forth. Ultimately, what happened and wasn't predicted is that people would just, flood the streets at the very same time. So restaurants are closed, they're shut, and then all the people in the streets just interacting and talking very closely without a face covering, because here it's not compulsory outside, with a very high risk of spreading the infection even more. But for example, even those face coverings, their use and their effectiveness is still highly debated, because there are some people who say, if people wear face coverings, then they might forget about social distancing, which shouldn't be the case, and so on and so forth. So we have to be mindful of the risk of unintended, unpredicted consequences whenever we deliver, development project, or in the case of policy programs, or in the case of health enhancing technologies in disadvantaged communities. So we need to understand that every impact needs to be situated, and we need to understand what works, so which outcome we are trying to achieve, for example, reduction of the virus transmission, with which mechanism, could be face coverings, in which context. So the national context, but also the sociocultural context of a slum is enormously important to understand which outcome we can expect to achieve with which mechanism. In order to achieve the same outcome, we might have to change the mechanism because of the contextual condition. So we need to understand what works for whom, in what circumstances, in what respects, and how. So how do you do then the evaluation of a policy program, or a new product, or the improved cooking stoves in the slums? There needs to be an outcome evaluation, but also a process evaluation, to appreciate the influence of the context and the influence of the implementation. So to what extent a product has been implemented, to what extent it has been used, what is the experience of people using it and of people installing, for example, the program. What we have done is, for example, to use this complex intervention lens to evaluate a multi-strategy community intervention to reduce maternal and child health inequalities in India. Now, coming back to our organizational forms, to our hybrid organizational forms, in the case of sustainable development and sustainable development goals, they do face quite a complex performance scenario, because they have to evaluate their business model, their products, at different levels, so at individual level, at organizational level, but also at systemic level. They have to evaluate them against different performance dimensions, which are economic, environmental, and social, and also in different contexts, which is both a temporal context, so intragenerational and intergenerational, and also spatial context, so in different kind of context. In this sense, we have been using increasingly a learning from performance feedback lens. And we see that learning from performance feedback in this situation is particularly complex and challenging, because you sort of learn, you have to use different performance dimensions. Now, the learning from performance feedback intends adaptations, organizational adaptations, as actions or organizational changes aimed to close the performance gaps. And in this case, we studied project networks aimed at delivering humanitarian and development aid. These project networks are composed by beneficiary communities, local NGOs, international NGOs, country offices and headquarters, and donors. And all these stakeholders have different perspectives on how to conceptualize social impact, how to measure it, and what is really social impact, and how to measure performance. So, for example, what we know is that the donors are much more focused on the short-term perspective, the bookkeeping, the accountability, while NGOs are much more focused on a long-term impact. And there are a number of tensions that arise because of this. we identified 6 paradoxical tensions. Now, I'm not going to go through it too much in detail, but once again, this is a qualitative project, and you see in brackets, so these are the second order themes, and the one on the right side are the aggregate themes. And we identified a temporal paradox between short-termness of projects and high staff turnover as a barrier to learning. So short-term versus long-term impact goals. Difference paradox, learning paradox. So there is a possibility to learn within the project, but projects are so unique because they cater to unique communities because of unique needs, that is quite difficult to actually learn and to share, to distill best practices for other projects. There is an identity paradox because the evolution of different actors within the network is evolving over time and is not always clear. There is a distance paradox because donors are typically far away from the field and they do not have the grasp of communities' needs as much as NGOs do. And there is a performance paradox. So there is a difficulty to evaluate social performance and attentions across theory of change results. So between output, outcomes, and long-term impact. Now, how do organizations then deal with such tensions? The learning from performance theory highlights how the difference between aspired and actual performance level trigger adaptive responses aimed to close the performance gap. Now, interestingly, what we have seen is that organizations cope with such paradoxes and tensions through 3 main adaptive responses or adaptive mechanisms. So they adapt really the monitoring and evaluation practices according to the specific network and according to the specific project. They set their goals in a collective way. So they have a collective goal setting, and they continuously renegotiate aspiration level. So during the course of the project, they do not have a set performance goal, but they do continuously renegotiate this over time. And through these 3 adaptive responses, they manage to deal with these paradoxes and tensions. Now, where do I go from here? So I'm currently busy with new projects that are able to unpack adaptive responses and learning dynamics. For example, I have a current project on hospital social capital variation based on historical versus peer underperformance, and on quality of care versus financial indicators. And this I'm doing with data from the NHS. And I also have a current project on learning and adaptation in multi-stakeholder partnership for sustainable farming in Malawi. And a second trajectory is unpacking performance scenarios with different levels of complexities along dimensions such as causal attribution and ambiguity. So to what extent we can actually attribute, let's say, the adaptiveness or the organizational change to the ultimate performance that we are trying to measure and to close the gap with. Especially if we are looking at social impact and social performance, it is enormously difficult to actually attribute and to disentangle the different causes of social impact. Then there is an element of performance temporality, different performance goals. So how do organizations deal with different performance goals, especially when they have to be pursued on an equal footing and there's no clear hierarchy between them? Think about environmental, social, and financial goals. And what is the interdependence of these performance dimensions? Current projects on organizational learning towards SDGs in the palm oil sector in India, which has an important, environmental and social repercussion there, but also organizational learning in the medical device sector, where we look at the reduction of failure rates over time based on large and small failure experiences. Now, thank you very much. I'm finished my talk for today.